To all the participants for the mental health awareness program. I'm very happy that it is going on very nicely for the past 3 days, 3 consecutive days. On behalf of KAHO, I welcome Dr. Naveen Kumar for the today's training program. The topic is a very interesting topic, that is on depression. And I also welcome Dr. Rini Joseph to moderate the session throughout. Now, I request Dr. Rini Joseph to take over the session and then start by introducing Dr. Naveen Kumar. Thank you very much. Over to Dr. Rini Joseph.
Thank you, sir. So, good evening, everyone. Welcome to the third session of our KAHO training webinar series. Today, our topic is on depression, Dr. Ravi had said. I am pleased to reintroduce Dr. Naveen Kumar C, who is currently serving as the professor and head of the Community Psychiatry Unit at NIMHANS, Bangalore. He also serves as a consultant for the Forensic Psychiatry Services and the Telemedicine Center at NIMHANS. Additionally, he is the officer in charge at the Center of Excellence on Climate Change and Mental Health and principal investigator for the National Tele-Mental Health Program, TeleManas. His extensive work and dedication have earned him numerous prestigious awards. There is no doubt that he brings a wealth of knowledge and experience to our session today. Without further ado, please join me in welcoming Dr. Naveen Kumar C.
Thank you, Rini, and thank you, Dr. Ravi Kumar. It's my pleasure to be part of this program. Again, it's my pleasure to be part of this program and talk about depression. So depression being one of the very, very commonly prevalent mental health disorders, up to 4 or 5% of the population may have experienced a depressive episode at least once in their lifetime. And the global burden of depression is quite heavy, contributing to the significant proportion of the disability adjusted life years that is lost. So the GBD is quite high for depression. So before we start, I'd like to request access to our, share the presentation. First, I think we will have a video, a small role play that our students have done. First, let us look at this video. It is about 4 to 5 minutes. So I'd like all of you to just carefully go through this. And after that, I'll be talking to you about various aspects of depression, starting from depression as a clinical construct, and then how the epidemiology of depression, what's wrong in the brain, and what are the treatment modalities available. So we all understand that it is just an awareness class. So I'll just brushing through all the concepts. And hopefully we will have some time for discussion as well in the end. It may appear as though there's a lot of information overload. I'll try and make it as simple as possible. Okay. So first, I think we'll start with the video. I kindly request all of you to just go through it. Yes, please.
नमस्ते सर।
जी नमस्ते।
मेरा नाम पूजा है, मैं यहाँ बगल के सरकारी अस्पताल में काम करती हूँ।
बताइए कैसे आना हुआ आपका यहाँ पर?
तो हमारे अस्पताल वाले घर घर जाके देखना चाहते हैं कि किसी व्यक्ति को कोई मानसिक तौर पे कोई दिक्कतें हो रही हैं।
मानसिक बीमारी?
जी, दिक्कतें जैसे कि दूसरों से बातचीत करने में दिक्कत होना, काम में अड़चन आना, काम पे नहीं जा पाना, मन उदास रहना, उस तरह के कोई लक्षण?
नहीं, ये सब तो देखिए काफी मामूली चीजें हैं। ऐसे मामूली उतार चढ़ाव होते रहते हैं, आपको भी होते होंगे, हमको भी होते हैं। तो हमारे घर में तो ऐसा कोई नहीं है, आप जा सकते हैं।
जी, मैं जानती हूँ आप क्या बोलना चाहते हैं, लेकिन देखिए ये लक्षण कभी कुछ ज्यादा हो जाते हैं। उस समय नींद पे असर पड़ना, नींद नहीं आना, खाना ना खा पाना, काम पे बिल्कुल भी नहीं जाना, हाथ पैर में दर्द रहना, उदासी छाई रहना, बहुत कमजोर महसूस करना, ये सब लक्षण भी हो सकते हैं। ऐसा कोई व्यक्ति है आपके घर पे?
हाँ, वैसे मेरी बेटी है मीना, वो 1 महीने से काम पर नहीं जा रही है, यही सब जो आप बोल रही है ना। बट मुझे लगता नहीं है उसे कोई दिक्कत है, बस थोड़ी उदास है वो, हमारी घर की समस्याएं हैं।
क्या हम उनसे मिल सकते हैं?
नहीं, बट उससे कोई प्रॉब्लम नहीं, मुझे नहीं लगता उसे कोई बड़ी बीमारी है। वो थोड़ी कमजोर है, थोड़ी नाजुक है, वो ठीक हो जाएगी।
हम उनसे मिलना चाहेंगे सर।
ठीक है, 1 मिनट रुकिए। मीना, अरे ओ मीना, जरा यहाँ आओ तनिक।
क्या हुआ पिताजी?
मीना देखो, ये पूजा मैडम है, नजदीकी अस्पताल से आई है, तुमसे बात करना चाहती है कुछ। बैठो, बात कर लो। आप भी बैठिए मैडम।
नमस्ते मीना, मेरा नाम पूजा है, मैं यहाँ पे सरकारी अस्पताल में काम करती हूँ। कैसी हैं आप?
मैं ठीक हूँ।
ओके, आपके पिताजी बता रहे थे कि आपको कोई मुश्किल हो रही है, उसके बारे में बता सकती हैं आप?
क्या बताऊँ मैडम आपको, मेरे पति शराब लेते हैं, पिछले कुछ महीनों से ज्यादा ही ले रहे हैं, घर के सारे पैसे उसमें उड़ा देते हैं। मैं अपने बच्चों के स्कूल की फीस तक नहीं भर पा रही हूँ, अपने पिताजी की दवाइयों का खर्च भी नहीं उठा पा रही हूँ। पूरे समय उदासी छाई रहती है, कुछ उम्मीद महसूस नहीं होती है।
तो आपने बताया कि आपको बहुत पारिवारिक मुश्किलें हो रही हैं, आपकी नींद कैसी है?
नींद बिल्कुल नहीं आती है, सोने की बहुत कोशिश करती हूँ, हर समय करवटें बदलते रहती हूँ।
ओके, और आपका खाना?
भूख तो जैसे गायब ही हो गई है। पहले जिस तरह खाने में रुचि रहती थी, जैसे खुशी मिलती थी, अब वो कुछ नहीं बचा है।
ओके, और आपका दूसरों से घुल मिलना, उसमें कोई बदलाव आया है?
अकेले रहने का मन करता है, लोगों से बातचीत करने का मन बिल्कुल नहीं करता है।
तो जैसा कि हम देख रहे हैं कि ये जो आप समस्याएं बता रही हैं, ये मामूली से थोड़ी अधिक लगती है। आपको लगता है कि आप इससे बाहर निकल पाएंगी अपने आप?
मैं नहीं जानती।
ओके, क्या आप पसंद करेंगे कि इसके लिए आप कोई इलाज लें?
शायद।
ओके, तो आप जानती हैं कि यहाँ पे सरकारी अस्पताल है, आप एक बार डॉक्टर साहब से आके मिलिए, वो देखेंगे आपको, अगर उनको जरूरत लगेगी तो आपको कोई ट्रीटमेंट पे शुरू करेंगे। आप आएंगी?
आऊंगी।
सर जरूर लेके आइएगा।
अभी खुश होने के लिए भी हमें दवाई लेनी पड़ेगी? कोई बात नहीं, देखते हैं।
नमस्ते सर।
जी नमस्ते।
नमस्ते मीना, कैसी हो?
नमस्ते मैडम, मैं ठीक हूँ, लेकिन उदासी अभी भी थोड़ी रहती है, कामों में दिलचस्पी थोड़ी कम है।
ओके, अच्छा लगा जान के कि आप बेहतर हो रही हैं। डॉक्टर साहब ने क्या बताया है आपको आपकी उलझनों के बारे में?
उन्होंने मुझे बताया था कि मुझे मन की उदासी है, और ये उदासी मामूली उतार चढ़ाव से थोड़ी ज्यादा है, और मुझे दवाई लेने की जरूरत पड़ेगी। इस दवाई का असर होने में थोड़ा समय लगेगा, और तब तक के लिए ये उतार चढ़ाव नॉर्मल है।
अच्छा, तो डॉक्टर साहब ने आपको आपकी जीवन शैली में कुछ बदलाव लाने के लिए बताया?
जी हाँ, उन्होंने मुझे कहा था कि मुझे व्यस्त रहना चाहिए, लेकिन मुझे उन सब चीजों में दिलचस्पी नहीं महसूस होती है।
तो जैसे कि आपने बताया कि डॉक्टर साहब ने बताया है कि ये जो दवाइयां हैं इनको असर करने में कुछ समय लगेगा, तो उस समय आप अपने आप को उन कार्यों में व्यस्त रखिए जिसमें आपको रुचि है, जिस चीजों को करने में आपको बहुत आनंद आता है। दूसरों से चाहे बात करना हो, आस पड़ोस लोगों से बात करना हो, बच्चों से, अपने पिताजी से, तो उस कार्य में आप व्यस्त रहेंगे तो ठीक रहेगा। उसके अलावा दवाइयां आप चलाइए जैसे चल रही है, बिल्कुल भी बंद नहीं करना है इन दवाइयों को जब तक डॉक्टर साहब ना बताएं, ठीक है? और महीना महीना डॉक्टर साहब को जाकर मिलिएगा।
जरूर जरूर मैडम।
और इन आपकी जो भी समस्या है उसमें कोई भी परिवर्तन आए या बढ़ जाए तो आप जाके डॉक्टर साहब से उसके बारे में डिस्कस कर सकती हैं।
जरूर मैडम।
ओके, तो मैं आपको मिलती हूँ अगले महीने के घर पे।
जरूर।
ठीक है, नमस्ते।
Okay, so this is the video. Just hold on to your thoughts. Let me complete the presentation, and then we can have some good 20 minutes for discussion. This is going to be the outline of my presentation as I initially discussed. We'll talk about definitions and various abnormalities in the brain that is that is present in a case of depressive disorder, how commonly it is prevalent in the community, the comorbidities and the management. So I think we have already watched the video. It was a depiction of a health worker, a community health worker, going to a house visit, and she had helped screen out a case of depressive illness, and then she was able to help them out to network them to a nearest health facility. And you all saw how there was description of what the clinical features were, and what kind of misconceptions the family may have with regards to depression in particular and mental illness in general. And you also saw what happened, the outcome of the patient visiting a hospital, and she had improved well. And of course, still many more things to do with that particular person, because her depression had the antecedents of the social issues, like the husband was not earning, and a lot of sociological factors were present in that particular case. So you need to manage that as well. It's not just about taking pills and reducing the symptoms, but some interventions will have to be done for the comorbid issues as well. So be that as it may, we will just understand depression as a clinical construct. So it basically, depression is a common mental illnesses that negatively affects how we think, act, feel, and how we perceive the world. Basically, it is an emotional disorder wherein the dysregulation is primarily in the control of our emotions. Predominantly negative emotion is present in case of depressive disorder. Rest of the abnormalities, like the negative thoughts, the negative behavior, and how we perceive ourselves, also the world, they are all colored by the negative emotional state, which is thought to be the primary dysfunction in a case of depression. Of course, there are a lot of definitions. I will not go into the details of this. So one important conceptual issue I want you to understand, that is how to differentiate normal human sadness. Sadness is a normal human, it's a universal human emotion, isn't it? There is no human being in the world who has not experienced sadness in his or her life. But how to differentiate that sadness with depression? That is the question. One is, of course, the sadness. It is usually associated with one or other, negative life event or any, issues in life. Depression may or may not be associated with a life event. Like, for example, typical example I often give is that if I fail in an exam, it is natural for me to feel sad. Maybe 1 day or 2 days or 3 days continuously I may feel sad. That we don't call it as depression. But I continue to feel sad even after 1 month after the result is announced. Then the alarm bells will ring, and then you need to think of a presence of depression. So that is the kind of illness. And of course, sadness is temporary and will pass away with time, unlike depression. Generally, the normal sadness, it doesn't affect the functioning. For example, if I'm feeling sad because I have lost my exam, if my friends come and talk to me, and the sadness will go away and I feel happy interacting with them. That may not be the case with depression. When you talk of the duration, sadness is brief, last longer. One may ask as to how long. So the answer is 2 weeks. That is what the various diagnostic criteria mentioned. If the sadness is persistent for 2 weeks or more on a continuous basis, then I think whatever be the cause, it could be a death of the loved one, it could be a grief, it could be financial loss, or whatever it is, depression is said to be present if certain other criteria apart from sadness is present. So the duration criteria is supported. So that is what that is how we diagnose depression. So again, I'll not go into the details. As I've said, 2 weeks or more symptoms have to be present. Various symptoms are listed out. Of course, depressed mood is a primary symptom. Loss of interest and enjoyment, particularly in previously pleasurable activities. That is called as anhedonia. I think that is one of the important markers for the presence of depression. And of course, getting easily fatigued. So these three are called as the cardinal symptoms of depression. At least 2 of these 3 should be there, and a whole list of other symptoms are there. Like, for example, reduced attention and concentration, reduced self-esteem, negative views about the self, about the future, and ideas and acts of self-harm, disturbed sleep, diminished appetite, reduction in weight, and so on and so on. There's so many other symptoms. Also, a particular set of symptoms, which is called the somatic symptoms, may or may not be present in all depressive symptoms. As I was saying, anhedonia is already mentioned. Lack of emotional reactions to events that normally produce an emotional response. Lack of emotional reactivity is what we call. And if the person wakes up 2 hours or more before the usual time, then that is a somatic symptom. Depression, which is worse in the morning. And objective evidence of marked retardation or agitation, as reported by other people. The motor activity gets very much slowed. The thoughts won't get generated as fast as it used to be. Marked loss of appetite and loss of weight by at least 5%. So all these are called as somatic symptoms because in patients with these symptoms, it is thought to be biologically generated. That means that there is a high genetic vulnerability in such patients. Patients with these depressive symptoms, I have already told what are the criteria to diagnose depressive disorder. In the depressive disorder, if these symptoms are present, then it is thought to be biologically generating, in the sense because as you have seen in the video, a lot of psychosocial problems also may lead to the development of depression. But if so in such cases, these somatic symptoms may not be present. If the somatic symptoms are present, it is likely that without any stress or without any life event, the person is vulnerable to develop depressive episodes often in life again and again. So that is about diagnosis of depression. Clinical subtypes I was talking about. So depressive episode typically is a recurrent illness. Like if a person has one episode of depression, it usually presents for about, which will be present for about 6 months to 9 months. And generally the tendency is it will, resolve generally. But very rarely the depression also can get prolonged. Also, it is a recurrent illness. That is, if a person develops one episode of depression in life, the chances are, very good chances are for that person to develop episodes often. People have calculated in a person with 70 years of human life, and on an average 4 or 5 episodes of depression a person can have if the person has only recurrent depressive disorder. Depression can also be present as part of bipolar disorder, wherein the depression alternates with an opposite spectrum of symptoms, which is called as a mania or hypomania. I am not going to the details of the bipolar spectrum. I'll just restrict it today to depressive episode. So 4 to 5 episodes a person is likely to experience in his entire lifetime. So recurrent depressive disorder, I have said, I'll not go into the details. I'm not going to bore with these details. And other thing is that you'll also have to differentiate depression from adjustment disorder. I initially spoke about sadness, normal human sadness, and how to differentiate it from a depressive disorder. Likewise, there is another entity called as adjustment disorder, which is actually not a depressive episode. Now, how to differentiate it from depressive disorder? Clearly, one stressor has to be identified immediately or preceding the onset of a depressive episode. Some symptoms of depression will be there, but full diagnosis of depression cannot be made out in that particular patient. So that is one important differentiating factor between adjustment and disorder. And of course, a stressor is a must for the presence of adjustment disorder. Again, so many other criteria is there. I won't go into the details of that, but any an episode of illness which does not fulfill the criteria for depression, but preceded by a stress, that is one thing. Now there is another construct called as dysthymia, which again is a minor variety of depression, you could say, but subsyndromal depression is a term that we usually call for those with dysthymia features. The symptoms have to be present for more than 2 years. In those first 2 years, there has never been a 2-week period in which, there has never been a 2-week symptom-free period. I think there is a mistake there. I think we need to be cognizant of that. Functionality is maintained. I mean, functionality means whatever the role is assigned to a particular individual, that will be maintained with a lot of effort. It's not an automatic thing for that particular person. So that is how you differentiate it, because these things may appear confusing, but these things are present in our community, which is why there is a lot of circus to fit these things into some sort of criteria and to give some separate names for that. But let me tell you, most of the times or many of the times, it is an intermixture of the picture that we come across in clinical scenarios. But for at least understanding, we need to be aware of these things. The other construct that we need to understand is grief versus depression. Like the grief is is actually seen when there is a recognizable loss of a loved person. So that is one thing. The other important feature is, of course, as I was telling, sometime previously, that at least 2 weeks period we need to give, and the sadness of the mood should be present continuously. There are so many other things in the explanation. I would not like to go into the details of that. You could actually just keep this in mind. There is a bereavement, and it is natural for anybody to feel depressed and sad, but it is not continuously present. The mood is reactive. The biological functions, as we say, the sleep and appetite, those things are generally not disturbed in a person with grief. And of course, it resolves within a period of 2 to 3 weeks if it is a grief. But there are so many other types of complicated griefs. I'll not go into the details of that. But for a general superficial understanding, I think this will be sufficient. But of course, the grief may be there, but if the person fulfills the criteria for a depressive episode as shown previously, beyond a 2-week period, that also qualifies for a depressive episode. The grief cycle, usually whenever there is a grief, there is a denial, there is anger, there is bargaining. When people struggle to find meaning and reach out to others, telling one's story, then depressive features are seen. Overwhelming feelings, helplessness, hostility, and flight, and acceptance. This is given by Kubler-Ross, which is called as a grief cycle. This is what is the usual cycle of emotion that one goes through when there is bereavement. So I have already spoken about this bipolar versus unipolar depression. So the history of mania or hypomania will not be present if it is a unipolar depressive episode. Unipolar depressions, that is depressive episodes occurring again and again, is more common in women, but bipolar disorder or bipolar depression is equal in both genders, both sexes. The age of onset is generally little late in unipolar depression, and the onset can be abrupt in bipolar depression. Generally, it is insidious onset in unipolar depression. Bipolar depression tends to be shorter in duration when compared to unipolar depression. So other differences are also given. So you need to be aware that two kinds of, these differentiations are important, and bipolar depressions are generally biological in nature, in the sense the somatic symptoms that I have spoken, those things tend to be more in bipolar depression vis-a-vis the unipolar depression. And of course, mania or hypomania gets interspersed. They can be hypomanic and manic symptoms can be part of the same depressive episode, which is then called as a mixed state, or many patients, many times we see pure depressive episode in a person with bipolar disorder after 2-3 months or years, or after about a decade, manic episode can come. So mania, depression, mania, all sorts of combination are seen in persons with bipolar disorder. Of course, there is a separate depression on a separate session on bipolar disorder where you will get more awareness in that. So coming to what's wrong, in our brain. Of course, depression is a biological illness. A strong biological component is there. So there are so many abnormalities are seen inside the brain. Of course, as soon as the child is born, the child cries. That means emotions are there at the birth itself. That means the deeper areas of the brain, they are in charge of controlling emotions. But of course, as the child grows, these emotions are also influenced by the thoughts or the thought process. The thought process or the self-direction, other higher level functioning will come once the cortex grows, but the emotions are primarily originating from the deeper areas of the brain, which is why you could see in this figure that there are imbalances of a lot of neurotransmitters, maybe norepinephrine and dopamine, and there are neurotransmitter imbalances. There is neuroinflammation, impairment of neurogenesis, that is decreased hippocampus volume is seen. And there is some sort of hippocampal atrophy also. There is dysfunction in synapse. So all these abnormalities are concentrated in core, deeper areas of the brain, that control emotions. That is the basic level of understanding. In fact, I am also not a specialist in biological psychiatry, so it will be difficult for me to go into the details of all these things, because much research has occurred and the field has grown enormously. But for the purposes of this today's discussion, I think it suffices to say that the deeper areas of the brain are involved, and which are these are the areas that are implicated in depression. As you see, majority of the areas are deep-seated areas. Say, take the example of insular cortex, the hippocampus. These are all part of the old brain, or the paleocortex. I keep forgetting that. But so amygdala, nucleus accumbens. And only 2 or 3 cortical areas are implicated in depression. So basically, there is a dysregulation in the functioning of the synapse. There is some cell loss due to various factors. It could be biological and psychosocial, and many a times both these are intertwined to cause all these abnormalities. And when we talk about treatment of depression, it has been shown that some or many of the abnormalities, they do get corrected. That is the action of the treatment modalities that we are going to learn in a while. So I was talking about the biopsychosocial model of depression. This biopsychosocial model is actually seen in all of the psychiatric disorders. At least that is the way the current understanding is. As you may see, the biological factors could be the abnormal brain structure, abnormal brain activity, there is circuit dysfunction, and so on and so forth. Added to that, if there are social factors such as social isolation and loneliness and so on, there are hundreds of social factors. Likewise, the personality factors also could be there. So all of these act together, and then it could lead to depression and functional impairment. So that is about what's wrong with the brain in persons with depression. So then what is the Indian scenario for epidemiology of depression? So again, we'll go back to the mental health survey, which, NMHS 1, which occurred in 2015, 2016. So you could see that, common mental disorders is about 10%, neurotic and stress-related disorders is about 3%, and depressive disorders are 2.68. For the purposes of current discussion, we will club both. Neurotic depression as well as depressive disorders, they come up to about 5%, and the severe depression, that is another point I'd like to make here. If the severity of depression increases, then there is a likelihood of more occurrence of biological factors in them. When we talk about mild and moderate depressive episodes, then the psychosocial factors do play a major role. So that is how general understanding is. So basically, about 5 to 6% of the population, they do have at least one depressive episode in their lifetimes. So the age and gender variations also are seen. You could see a slight increase of depressive problems in females. And as the age increases, the depressive prevalence also increases, and it sorts of stables down, say after 50 years of age. That is another variation. And of course, in the elderly, very, very high prevalences are seen. But of course, this has to be, replicated. But it's very, very concerning. This is a large-scale study, epidemiological study, which said that up to 26% of older men, above I think 65 years it was last year, I'm not very sure about the age. So that is, and 31% among old, that is about 1 in 3 elderly. They have, they may have experienced 1 or 2 episodes. The NMHS study, the age is actually not elderly. It is the age range was very wide. Like, for example, it's, I think it was 18 and above. So, but here it is, those with 65 years or more. So, as I was talking in my first class itself, there are a lot of comorbidities, psychiatric, medical, and of course, there is bidirectionality also. Here, you just look at the list, it is so huge. A lot of endocrine and metabolic abnormalities. Depression is seen in many neurological illnesses, infections, collagen disorders, nutritional problems, cancer, drugs. So many of them are associated with depression. So it is better to be aware that, many of you guys must have, we are working in various medical settings, critical care settings. So depression is one thing which you always have to keep in mind. When it comes to psychiatric comorbidities, also a lot of disorders are associated with depression. I would not go into the details of these things because it's too huge. So it's just you could see and what all disorders are associated with comorbidities of disorder. The clinical point here is, if you come across any of these disorders, it is always necessary to check about comorbid depression also. That's what it is. And of course, the bidirectionality, I was talking about it in my previous class also. Anemia, tuberculosis, diabetes, hypertension, and vitamin B12 deficiency, vitamin D deficiency, all these things can be associated with depression. And depression also can be associated with all these things. For example, simple explanation for anemia is I lose appetite and I don't take proper nutrition, and that can lead to anemia. The same thing with vitamin B12 deficiency also. And the diabetes, if diabetes is there, the fatigue, which is part of diabetes, can be mistaken for depression, or chronic diabetes may lead to chronic feelings of sadness and so on and so forth. So now coming to the management, I think I've come to the last part, maybe another 4 or 5 slides are there. So what is the assessment and what are the treatment approaches? But when you come across treatment approaches, there are both pharmacological as well as non-pharmacological, that's psychological and psychosocial management. Of course, a complete history you have to take, complete physical examination you have to do. You have to rule out secondary causes of depression. You assess the severity, evaluate the symptom severity, and basic, investigations may be required. And of course, additional or optional assessments are there. So you need to be cognizant of that as well. When it comes to the treatment, you should always know of phases of treatment. That is, we always, when we start treatment, we talk about the acute phase of treatment, then the continuation phase, and the maintenance phase for each depressive episode. The acute phase lasts for about 6 to 8 weeks. The continuation phase is for about 6 months, and the maintenance phase is for about 2 years. So, continuation phase is to prevent relapse. That is the recurrence of the same episode. The patient may have improved, but then it should not come back again before he recovers completely. So it all, so many other complexities are there. I'm not going to the details of that, but the general message here is, if one person has one episode of depression is generally 1 to 2 years is the range of duration of treatment for one episode. So I think that if that is a message, I think that's enough. There are a lot of agents, pharmacotherapeutic agents. When tricyclic antidepressants were there in 60s and 70s, they are very good drugs, but at the same time, a lot of side effects. So in the 80s onwards, a lot of other newer drugs which are very, very safe, called as the SSRIs came. And a lot of them that are available now, we can use one of them. There's so many other, based on the putative mechanisms, there are so many other classes of antidepressants have come. It's called as the NSRIs, the NSREs, the noradrenaline specific serotonin antagonist. So many other drugs have come. We could use one of them in treating depression. There are a lot of psychological therapies. I'm not going to the details once again. You could just see and know that there are a lot of therapies such as cognitive behavior therapy, interpersonal mindfulness. There are so many other things. Of course, very basic education is essential for all of them. I mean, if a doctor sees a person with depression, he should or she should emphasize that depression is treatable. You should outline the treatment options. What are the effects? What are the side effects? What is the duration of treatment? What is the likely course? And also teach them how to recognize early signs of relapse and encourage healthy lifestyle choices. And of course, if specialized psychosocial therapies are required, we need to refer to them. Another important thing is a very potent tool to combat depression is the non-invasive brain stimulation. That is NIBS, we call it. ECT stands for electroconvulsive therapy. It is the oldest surviving biological treatment that psychiatry has seen. ECT, even before drugs, in the late 30s, ECT was invented. ECT stands for electroconvulsive therapy that uses controlled electric currents, very, very minor amount of electric currents to induce a brief seizure deliberately, of course, under anesthesia. And ECT is the most effective treatment, biological treatment for persons with severe depression. I'm not talking about mild or moderate depression, but I have no doubt in my mind that is one of the safest and most effective treatments that are currently available, for a person with biological depression, for a person with severe depressive episodes. There are other, NIBS options such as recurrent transcranial magnetic stimulation, which uses pulses of magnetic energy to stimulate specific brain regions. ECT, if an alternating current is passed, the entire brain gets stimulated and it results in a generalized seizure. Many of you may have worked in psychiatry, inpatient psychiatry settings. You may have seen that under controlled conditions, that is under anesthetic procedure. But NIBS, RTMS, there is no requirement for anesthesia. It does not induce a seizure. It just stimulates a very, very minor portion of the brain through the magnetic energy. There are so many other treatments, but I will not go into the details. So take-home points is that it is a common mental disorders that adversely affect how you feel. I think the emotional dysregulation is the basic feature, and that influences our thoughts, our thinking, our worldviews as well. It is primarily a clinical diagnosis. All the other things are actually done to rule out the presence of organic factors. You may get an MRI, you may get a blood test and other things, but all that is to rule out the possibility of organic factors. So the etiology can be explained through biopsychosocial model. And of course, it is essential to differentiate the sadness from depression. It's very, very highly comorbid in nature, bidirectionality, and of course, the treatment options include the pharmacological, psychological, psychosocial, and NIBS, that is non-invasive brain stimulation methods. So I would like to stop today's class, and of course, I acknowledge my younger colleagues. Rini is there in this current with me. So Prerana, Aditya, Megha, Maryada, and of course, Bhavika and Makaran and Swarnali. Those were my students, and they actually, we had done that role play for another program. I thought we could use it here as well. So I'd like to stop here. And of course, so many references are there, and we can have now some discussions on the topic.
From Ms. Shailaja Ahuja, and she asked if the depression is genetic in nature.
Yes, thanks, ma'am, for the question. When we say genetic, it is not an autosomal dominant or autosomal recessive. Such kind of inheritance is not seen in psychiatric disorders. But what we should understand is that depression, depression has some genetic contributions as well. For example, if you look at if you compare two groups of people, who have experienced depression, the persons or the parents who have experienced depression, their progeny is much more their children are much more likely to develop depression than those parents who have never experienced depression. So the presence of family history is important, but how much of variance is explained by genetic, it's tough to say. Which is why we always talk about the contribution of other factors as well. The social factors that you saw in that the video, the other personality factors, and so many other factors to come into play. And of course, genetic factors are more if a person has more severity of depression. So the more severe is the depression, the more is the genetic factor. That much I can say.
Thank you, sir. There is Miss Pujaita Chatterjee who has raised her hand. So
yes, ma'am, please.
Miss Pujaita Chatterjee.
Maybe we could move on to the next question if at all anything is there.
Everyone is thanking for the session and also asking for the presentation.
Okay.
So
I think we can share it. I think that's not a problem at all. It was just an orientation session on depression.
Don't see there are
no more questions. Okay. I think Dr. Vishram Kulkarni, yeah, you can just.
So Dr. Vishram Kulkarni asked if anxiety and depression are both sides of one coin.
Actually, sir, it's actually a difficult question because we conceptualized anxiety as one form of emotion. Depression is another form of emotion, and predominant problems in regulation of anxiety, there are different circuits are involved basically. And there are, when we look at it from the clinical point of view, we differentiate anxiety disorders from depressive disorders. Because if you look at, say, panic disorder or a generalized anxiety disorder or a social phobia, there are many different disorders which they may not have depressive features, depressive episodes at all. They may, in fact, they may have comorbid depressive episodes, but without comorbidity also, we see a lot of disorders in which the predominant disturbance is, related to anxiety and fear. For example, social phobia, a person, endures the social situation with a lot of anxiety and not with depression. Very commonly, we call it as stage fear. The person will be absolutely normal if he or she is not on the stage. But if at all the person is pushed to go and speak in front of the stage, a person gets terrified and feels anxious. Another common example of anxiety is called as agoraphobia, wherein a person feels fearful to go outside of the house. Like, for example, if a person is asked to go on a train alone or a crowded place, the person feels petrified and feels anxious. So that is different. So those people may not have depression at all. Another, example is generalized anxiety disorder, wherein for minor day-to-day issues and affairs, the person gets excessively worried about, normal day-to-day affairs, and they start having anxiety symptoms in the form of headaches or feelings of tension or other autonomic symptoms they may have. So what I want to emphasize is, while depression and anxiety may be comorbid, there are very many cases in which they are distinctively different from one another. So that is where I'd like to stop. Of course, the treatment for the pharmacologic treatment almost similar, because other thing I would like to tell here is the very little neurobiological understanding we have for psychiatric disorders. And what understanding we have is that the serotonergic dysfunction is present both in anxiety disorders as well as depressive disorders. But the circuits are, the anatomical circuits are a bit different. But there also serotonergic receptors are involved. Here also serotonergic receptors are involved, which is why SSRIs are the treatments for both anxiety disorders as well as depressive disorders. I'd like to stop here.
Thank you, sir.
Of course, the tricyclic antidepressants are not much effective against anxiety disorders. They're more specific towards, depressive disorders.
So Dr. Anshika asks, what are the signs of depression that is severe enough to need professional help?
No, so I was actually talking on the day one itself. Whether it is anxiety, whether it is depression, or whether it is psychosis, or whatever it is, I think 2 Ds we have to be careful about. That is, one is distress. That is the person feeling of constant distress inside one's mind. The other one is dysfunction. If the person is not able to carry out the expected and designated role in the society, that is when the alarm bells should ring and one should seek professional help.
Ms. Surbi Kala asks, how to deal with sadness and stress?
I think last week we have had a very good session on how to handle stress and how to cope with stress and other things. While stress is part and parcel of life, depression is a medical illness. So I think professional help is required for handling depression. Of course, mild, moderate depression, the approaches are different, and persons with severe depressions, the approaches are different. But some self-help strategies, the lifestyle modifications, and developing some coping skills, and these things, stress management techniques, there are so many of them. So these are the approaches for dealing with stress.
And Ms. Dhanya Michael asks, what is the role of technology as the root cause of depression?
Yes, I think nowadays it's very, very relevant. I'd like to share one, a piece of information. When Jonathan Haidt is a renowned clinical psychologist in the US, he has promulgated that post 2012, the year 2012 is when the Instagram got introduced. So he divides the period between pre-2012 and post-2012. And post-2012, depression and anxiety among young adults has increased 200%. Not only in the United States of America, but whole of the developed world, that is Canada, UK, Australia, and other developed nations. So, of course, this is a very, very relevant question. So, people are getting addicted to technology, which is called the behavioral addiction. It is an emerging problem. And of course, there are a lot of correlations between addictions to these kind of behaviors and depression and anxiety. I think it's a it's an emerging public health problem. There is no doubt about it. That's what my feeling is.
Mr. Farah Amir asked, does certain type of environment while growing up make children more susceptible to depression?
No, it's a very vague question. Of course, there is a lot of correlation between, deprived environment, let me put it that way. Particularly if it is present for a long time, that is bound to have deleterious effects on children. Say, for example, children who have experienced trauma in their young age, they are very likely to have not only depression, but personality problems and substance use and so on and so forth, and many other things. So let me put it that way.
How to educate people on the danger of self-diagnosis? Dr. Grace is asking.
It's a tough question, I think, but there is no other way but to give authentic information from authentic source. I think educating people about the psychiatric disorders, how common they are, and how to prevent those disorders. I think we all have to take upon ourselves various means. Now the social media is there, and the awareness is quite high. So we will have to take upon ourselves to engage with people, to interact with more and more people through social media, to spread across authentic information. That's the only way. I think there's no other way.
Thank you. Ms. Anita asked, I wanted to know about the role of meditation in managing depression, as
Yes.
it is seen in many places and people are claiming it helps in curing this. Please
Yes.
appreciate
See,
your opinion.
my view on this is very clear. Meditation or any other psychological techniques or therapies or whatever, they're adjuvants to treatment. See, it depends on what kind of depression one has. If a person has suicidal depression is generally seen in persons with severe depression. Let us not say suicidal. If a person has severe depression, if one comes and says that I will just do meditation and I will cure you, I wouldn't accept that. However, if the depression is mild, and the person is not willing to take medication, and then we say the person has willingness to go and do the meditation, well and good, yes, you please go. Also, the person with severe depression, we could treat the severity with either medications plus ECT, or medication plus RTMS, and then the person the person's severity comes down a lot. And then if meditation has to be prescribed, yes, very good. So nowadays, a lot of integrative medicine efforts are being advocated, wherein approaches from various different medical streams are being integrated for a holistic care of a person. For example, in our institute, there is a department called the Integrative Medicine Department, wherein you have a specialist in Ayurveda, you have a specialist in yoga, you have a specialist in modern medicine. So if a person with depression goes there, the approaches from all these three streams will be given. The benefits of all these streams will be offered to the patient, and that is the way to go. Instead of either negating one system of medicine and taking only one side, it's always the integrative approach which augurs well for the patient. And patient also, we need to respect patient's choice as well. If the person simply refuses ECT, there is no way we are going to give ECT unless he is dangerous to others or self. If the person has capacity to undertake mental health care and treatment decisions, there is even the Mental Health Care Act prohibits a clinician or a physician to go against the patient's will. So which is why it is always a collaborative effort. It's an engagement. You give information to the patient, address all his or her concerns, take proper consent, and only then go about initiating treatments, whatever it could be.
Ms. Mohammadi Begum asked, do children get depression?
Yes, particularly those with genetic vulnerabilities. Children as young as 5, I have seen children becoming depressed, and if the childhood onset of depression is one of the most severest problems that one could face, because it doesn't augur well for the future at all. In fact, why only depression? Any psychiatric disorder that has its onset in childhood, the prognosis is actually bad. That is one thing. So, and of course, yes, we have seen persons in children developing depression. There's no doubt about that.
Ms. Pujaita Chatterjee can ask the question by unmuting.
Yes, Ms. Chatterjee. Okay, I think ma'am is not.
Another question by Dr. Vishram Kulkarni is, what are some home-based preventable remedies one can try?
I think I can't answer this question straight away, but to be very, very generalist, I think meditation is one aspect. There are various kinds of meditation. It could be meditations, or maybe the pranayama and other things, lifestyle changes, physical exercises, taking time for oneself, and there are so many things like preventive strategies for depression. It could be another class in itself. Developing techniques to handle conflicts, managing time, the handling relationships, reducing substance use. These are all very, very commonsensical things I'm saying, but these are the ones which can be used to prevent depression, of course.
One last question I think can take. Mr. Farah Amir asks, does long-term depression lead to other complex neurological diseases eventually?
It could be true. Maybe I would like to put it in another way. The chronic neurological illnesses can start with depressive features. Like, for example, frontotemporal dementia. Sometimes it becomes difficult for us to diagnose dementia. It could start with, say, depression, and then after some days it could progress. Actually, we know that it is dementia. That is very, very common. Not the other way around. If depression is purely depression, it's unlikely to lead to any neurological illnesses. But neurological illnesses can, the depression can be harbinger of a neurological illness. I think that particularly when it occurs in the elderly, one of the things that we do is to carefully follow them up and see if there are any progressive decline in the memory and other cognitive functions.
So chronic medical illnesses.
Yes, of course. Yes.